So as we know, CTV consists of deformities like pronation of forefoot adductors, hindfoot varus, cavus, equinus. You can also divide the deformities in terms of dynamic deformity, which is mainly caused by soft tissue, and rigid deformity, which is mainly bony. Foot has multiple joints functioning in different directions with different axes of rotation, and Ilizaro helps in three-dimensional correction of these deformities. Ilizaro works on the principles of distraction osteogenesis and Wolff's law. Ilizaro frame in CTEV consists of two types mainly: unconstrained frame and a constrained frame. In unconstrained frame, ankle joint and small joints of foot act as hinge, and in unconstrained type, the deformity correction occurs along the hinges we place in the axis of rotation of the ankle joint, which passes from the tip of the medial malleolus to the tip of the lateral malleolus. In an unconstrained frame, the deformity correction occurs along the in the ankle joint, which the ankle joint acts as a hinge. We have differential distraction technique to correct and realign the bones. In forefoot adductors, we distract medially more than the laterally, and in varus heel, we distract medially more and then laterally in order to correct the deformities and realign the bones. Likewise, cavus is corrected by distracting equally on either side, equally on both the sides. Ilizaro is indicated in neglected, relapse, and recurrent cases. My way of correcting the deformity starts with plantar fascia release, tendo-Achilles tenotomy, or Z lengthening if the deformity is very severe. I further go ahead and do a posterior capsulotomy, FHL lengthening, and in severe cases, I also do a dorsolateral wedge osteotomy. At the end, in case of severe deformity, I fix the toes to the frame with K-wires. This is a patient with bilateral severe neglected club foot. You can see the patient is walking on the talus. So here I proceeded with percutaneous plantar fascia release and percutaneous tendo-Achilles release. I usually take a 3 incision. The distal most incision will be medial, followed by lateral and then medial. And I forcefully dorsiflex in order to stretch the incised tendon. Further, the two full rings base frame is constructed and mounted onto the tibia. And calcaneal assembly is constructed by using a half ring, and forefoot assembly is constructed by using a half ring in the forefoot. So the tibial base ring and the calcaneum ring is connected with the help of a universal hinge, and the calcaneum and the forefoot frame is connected by 2 connecting rods, medially and laterally. This is how the unconstrained frame looks at the end. This is the post-operative walking video of a same patient, where both the feet has been corrected wonderfully, and patient is happy. A patient has a painless plantigrade foot. This is another patient, a 19-year-old boy, presented to me with a bilateral neglected club foot. He had a severe deformity, so I proceeded with plantar fascia release and did an open Z lengthening. In the same incision, we can approach the posterior ankle capsule and did a posterior ankle capsulotomy, FHL lengthening, and release of the talofibular ligament in the same incision. Later, the callosity was excised, and after retracting the foot tendons, dorsolateral wedge osteotomy is done, and the osteotomy site is fixed with multiple K-wires. So this is at the end of the procedure. The residual deformity will be corrected by gradual distraction with the Ilizaro frame. This is the pictorial presentation of dorsolateral wedge osteotomy. On the left side, this is the preoperative X-ray of the foot showing the varus deformity. After the osteotomy, the K-wires has been fixed. You can see the osteotomy is completely healed. And so this is the walking video of the same patient. Patient also had a knee deformity, but he refused to undergo knee surgery. This is the beauty of Ilizaro. Patient can do early weight bearing. So this is an important slide where it shows that how do we place the posterior motor rods, that is destruction rods. They should always be facing posteriorly and inferiorly in order to prevent subluxation of the talus. In some of the recurrent cases, I have used just fixator. These are some of the cases where the recurrent cases presented to me in my OPD. And this is how the just fixator looks. So this is the post-operative picture of some of the patient where the just was applied and deformity was completely corrected. The protocol for just fixator application is similar to Ilizaro, but here the distraction phase lasts for 1 week, followed by manual reposition. We have to take the patient to the OT under anesthesia. We have to remove the distractor, manually reposition, and then reapply the distractors. Once the deformity is completely corrected, holding patient is put in a holding phase where the fixator will be there, idle for 1 month to 6 weeks. So this is the problem I faced with just fixator, where there is when we try to correct the equinus, the force vector during correction directly transmitted to the talus, and it can displace the talus anteriorly, resulting in anterior subluxation of the talus. Compared to just fixator, I find Ilizaro very handy because any kind of severe deformity can be corrected, and any associated tibial torsion or a limb length discrepancy can be easily corrected with Ilizaro. And also we can achieve a acute correction as well as gradual correction after osteotomy. In all my cases, I make sure that that in recurrent residual or a neglected case, I do a tibialis anterior transfer at the time of frame removal. So this is a patient at the time of frame removal. I harvested the tendon from the medial cuneiform and first metatarsal and passed it underneath the skin on the lateral side. I drill a hole on the third cuneiform and pass the tendon on the lateral side, bring the tendon onto the plantar side, plantar aspect with the help of epidural needle, and then tie it onto the sole with the help of a rubber cap or a gauze piece. So this is the patient with dynamic varus deformity corrected with tibialis anterior transfer. It's an old fact that tibialis anterior transfer has been used for preventing relapse, relapse of the clubfoot. It gives this technique gives adequately corrects the muscle imbalance of the foot to prevent another relapse of deformity. And patients are allowed activity without additional bracing or restriction. Patient have a well-functioning foot with no more pain, difficulty with walking or medication compared to patients who do not undergo a transfer. Overcorrection was not found in this patient with up to 50 years of follow-up. These findings have been published in JBJS Essential 2015. I have a follow-up of 245 cases in my OPD register. I have a case of 16 cases of recurrent CTV, 18 cases of neglected CTV, and I have applied just fixator in 10 patients, and Ilizaro has been applied in 24 patients. In almost all the patients, deformities were corrected except in two neglected cases where the Pirani score was residual deformity of 0.5 Pirani score was present. So to conclude, our main objective should be to achieve a functional, pain-free, normal-looking, plantigrade, mobile, callus-free, and normal showable foot. Tibialis anterior transfer helps in overcoming the brace non-compliance and prevent recurrence. In resistant cases, plantar fascia release, endochleal stenotomy, and osteotomy should be used, and try to obtain correction in one surgery as much as possible. Thank you.